explain the physiological strategies needed to induce metabolic change. Then Dr. Kate Woolley from the UK will discuss the realities of patients' adherence, long-term sustainability, and how to address barriers in everyday practice. The last session will be led by Dr. Tehila Mazal from Israel. She will present practical behavior change techniques and communication skills tailored for the consultation room. Following this presentation, we will open the floor for a panel discussion and the Q&A, which you can put through the Q&A session alongside with the lectures. And then we will try to address the questions and help you find questions, the answers for your questions. So I want to wish all of us a highly productive and practical learning experience, and thank you for your time and dedication for advancing patient care. Dr. Pescara, please begin.
Hello, everyone. Thank you, Lilak, for that kind introduction. Let me share my presentation. Okay. Just confirm that you are seeing now it. Okay, I think yes, and it is already on
the... Yes, this is in presentation mode. Yeah.
Yeah, and I think it will start it before me. Sorry. Sorry, because it is not presenting, I suppose, to be.
Are you seeing? It was in presentation.
Okay. Are you seeing the presentation, right?
Not now. Now you're not sharing.
Okay. So just a moment, please. Sorry for this. Now it's okay, I think, and I hope.
Yes, just make it a presentation mode. Good. Okay. Perfect.
Okay, let's go. So, hello everyone once more. Greetings from Portugal. Thank you, Lilac, for that kind presentation. It's a real pleasure to be a part of this webinar alongside with my colleagues, Dr. Uli and Dr. Mazal. And over the few minutes, I will be talking about type 2 diabetes remission. And I hope to show that it is indeed a realistic, achievable goal in everyday primary care. Over my 2 sessions today, I want to make one central argument to you as fellow clinicians. Type 2 diabetes remission is no longer a theoretical curiosity, but it is indeed a measurable clinical goal, and that is indeed primary care the ideal setting to deliver it, okay? So in part 1, I will define remission precisely, look at the evidence base and discuss the paradigm shift in how we think about type 2 diabetes. In part 2, we'll get more practical, the evidence-based strategies that actually induce metabolic change and how to structure them in your own practice. My aim through this is to keep this rigorous, but also practical to your practice on Monday morning, for instance. So let's start with part 1. For decades, we were trained to view, as Lilac said, type 2 diabetes as an inexorably progressive disease, something we manage and slow down, but never reverse. Over the next 10 minutes, I want to challenge that framing, okay? We'll cover 3 things. First, a precise consensus-based definition of remission, because if we can't define it, we can't measure it, or aim for it, indeed. Second, the landmark trial evidence that has reshaped this field. And third, the mechanistic understanding of why and how remission actually happens at the level of the liver and pancreas. By the end of this part, I want you to leave with the conviction that remission is a legitimate clinical target to the right patients. So this slide captures the core paradigm shift, and I'd ask you to hold it in mind for the whole talk. On the left is the model most of us were trained in. So type 2 diabetes, a chronic, progressive disease, and the goal is centered on glycemic control. Pharmacotherapy is the cornerstone, and lifestyle is only an agent, not primary tool to manage that disease. Remission simply, it wasn't on the table, not considered, okay? So after that, on the last decade, the evidence tells us that remission is biological achievable. We know now substantial weight loss can put 40% of selected patients into remission, which is very exciting news. Critically, this is now formally recognized as of October 2025. There is a dedicated ICD, the International Coding of Disease 10, for type 2 diabetes in remission. So that matters. It means remission is a documentable, codable clinical state, not just a research endpoint, okay? This is very, very interesting and important in this topic. And the setting that's proven most effective is not the tertiary hospital, okay? It's primary care. It's our day-by-day practice. So the shift I'm asking you to consider is from lifestyle as afterthought to lifestyle as primary therapeutic tool. Everything that follows builds on this, okay? So, as I said, the 2025 ICD 10 code updates introduce a new code, E11.A, type 2 diabetes in remission, a landmark code that indeed allows clinicians to formally document patients who have achieved remission through lifestyle interventions, bariatric surgery also, or other approved approaches, okay? This milestone reflects growing recognition, and remission is possible and advances care that address the root causes of type 2 diabetes. That is very, very important. So, before we go further, we need a shared precise definition, as I said. Otherwise, remission becomes a loose and helpful word. So in 2021, it was the first international consensus published in diabetes care on behalf of ADA, the American Diabetes Association, also the European Association for the Study of Diabetes, also with Diabetes UK and others. And that consensus gives us exactly that, the definition that about remission. And that definition has three pillars. First, the glycemic criterion, and glycate under 38 mmol or 65%, depending on your country measures, achieved without any glucose-lowering pharmacotherapy. Second, the duration criterion, so that glycate must be measured at least 3 months after stopping all glucose-lowering medication, so we're sure it reflects underlying metabolism and not residual drug effects, okay? Third, the remission should follow an active intervention. Lifestyle is what brings here today us, but metabolic surgery and so on, okay? rather than being a transient, spontaneous fluctuation. So a practical note on language. I must say that it is very important that note. The consensus deliberately choose remission over cure or reversal, okay? Because relapse, it is indeed possible, and ongoing monitoring is needed. So it is remission, the word to this we are talking about. As I said, the new code gives finally us a way to record these states in the chart. So about the evidence, that evidence I'm showing to you underpins all of this. I've chosen 4 anchor studies. Look ahead in the New England Journal in 2013 is the important counterpoint, I think. Intensive lifestyle interventions produced real weight loss and metabolic improvement, but did not reduce cardiovascular events, and remission rates were indeed modest. The lesson is nuance. So this is weight loss, magnitude, and timing matter, and metabolic improvement and timing. And metabolic improvement doesn't automatically translate into heart cardiovascular outcomes. Then the most important, in my point of view, for our proposal, is the direct trial, the Diabetes Remission Clinical Trial, published in Lancet in 2018 with 2 years and 5 years follow-up. This is the trial that changed over all the conversation. It used a total diet replacement of around 80 to 80 and 50 kilocalories a day for 12 weeks, so a restricted caloric diet, delivered entirely in primary care setting. 46% of patients were in remission at 12 months. It is very, very interesting numbers. In those who lost 10 kilograms or more, remission rates were far higher. At 2 years, it was 36%, and durability data show remission can persist at 5 years. The key message is that was primary care-led delivery program and a feasible one also that conducted to that kind of results. 2 recent 2025 analyses sharpened the picture. So the Diabetes Care Systematic Review by Sherry Fowley and colleagues pulled 18 non-surgical randomized trials from 11 countries, a lot of persons, almost 8,000, and found that lifestyle-based interventions made type 2 diabetes remission roughly 6 times more likely than usual care, a risk ratio, as you can see, of 5.8, with the greatest benefit in a shorter duration diabetes. The second, a Lancet Diabetes and Endocrinology meta-analysis, quantified the dose response in this paradigm of remission in a continuous relationship that held independent of age, diabetes duration, baseline glycate, BMI, or the type of intervention. Concretely, a 30% weight loss was associated with about 50% complete remission rate, rising to near 80% above 30% weight loss. Of course, we are talking about huge percentages of weight loss, but the results are indeed very interesting. So the practical message of these studies is that weight loss is the central lever and there is no magic threshold. Every kilogram counts, which is a powerful and motivating thing to share with patients, okay? And if you take one trial away today, make it direct, okay? Because it proves that is deliverable and you can actually work in primary care with this. It helps enormously when counseling patients to understand why remission happens. So some authors describe a cycle hypothesis giving us a clear mechanistic story. And that is the story I bring to you in this slide. Energy restriction and weight loss come first, and there seems to be a threshold around 10 kilograms indeed that triggers the cascade. That weight loss depletes ectopic fat in the liver, which restores hepatic insulin sensitivity and normalizes fasting glucose, so starts here. Crucially, it then depletes intrapancreatic fat, and as that fat clears, beta cell function can recover with the return of first phase insulin secretion. In other words, the beta cell isn't necessarily dead, okay? In many patients, it's dormant and it can wake up. That mechanism picture directly explains the predictors at the bottom of the slide. Remission is indeed most likely with short diabetes duration. Under 6 years seems to be ideal. Greater weight loss, lower baseline glycate, and preserved beta cells reserve, which can gauge with C-peptide. Conversely, insulin-treated patients and those with very long-standing diabetes have lower remission rates because beta cells failure is more advanced. So when you select patients, and we'll come back to this in part 2, and you're essentially asking, is there enough beta cell reserve in this person, in this patient, to rescue? This is the question to go through. So that brings us indeed to part 2, the practical half. We've established that remission is real, defined and mechanistically explicable. Now, how do actually induce metabolic change? Nutrition is the single most powerful lever we have for remission. So let's spend a moment here. For evidence-based patterns on the left, the very low-calorie diet is the remission horse. This is the direct approach, indeed, as I presented to you. And as a huge result in remission, something like 46%. It produces the rapid, substantial weight loss that triggers the mechanism we just discussed. The Mediterranean diet has the strongest long-term and cardiovascular evidence, a lot of studies indeed, and it is far more sustainable for most patients are a maintenance pattern than the very low-calorie diet. Low carbohydrate approaches reliably lower glycate, also they improve insulin sensitivity, but they demand carefully and proactive medication adjustment. Don't forget that. And plant predominant high fiber, low saturated fat patterns improve also the whole cardiometabolic picture. Now the practical tips on the right. Which is where I'd focus your attention. Reserve a very low calorie diet for very motivated patients and always wrap it in structured support. Never just hand over a leaflet or something like that. Cut sugar sweetened beverage first. It's the highest yield single change. Screen also for fatty liver disease because 7 to 10% weight loss improves steatosis and also fibrosis. And the safety point I want you to remember, when you start a very low calorie diet, you must review glucose lowering medication immediately, and don't forget to keep it in mind. And at least, or at the end, not less important, finally, personalize. Ethnicity, food culture, and patient preferences determine whether any of these actually sustain. So about the second pillar of lifestyle medicine that really is important in this diabetes remission, we are talking about physical activity. And I want to be clear that it plays a different role from diet. Exercise alone rarely drives the large weight loss needed for remission, okay? But it's essential for improving insulin sensitive, preserving lean mass during weight loss, and sustaining remission long term. The three headlines number combined aerobic plus resistance training and lowers glycate by about almost 1%. That's very interesting indeed. So about exercise prescription, there is the practical core and aerobic exercise, at least 150 minutes a week of moderate activity, and reassure patients that 10 minutes bots count. That lowers the barriers enormously. Resistance training 2 to 3 times a week improves insulin sensitive independently of weight loss, so don't neglect it, okay? It's very important indeed. Combined training is superior to either alone, and the one many of us forget, sedentary breaks. Dempsey and his colleagues showed that interrupting prolonged CT every 30 minutes, only 30 minutes, with just 3 minutes of light activity meaningfully improves postprandial glucose and insulin sensitivity. That's advice every desk-bound patients can act on today. And my practical framing: prescribe exercise like a medication. Specify type, dose, frequency, and progression, okay? It's very important. I think I'm running out of time.
Yeah, sorry, Rosalia, you have 2 minutes.
2 minutes? Okay, let's
2 minutes.
Diet and physical activity receive most of the attention, largely because of the growing body of evidence supporting their role in diabetes remission. However, it is important not to overlook the contribution of the other lifestyle pillars and social determinants of health, but my colleagues will talk about that. Therefore, on this slide, I would only to have 3 comments. First, social connectedness. Social isolation is an independent factor, a risk factor, while group-based and peer support interventions consistently improves adherence and clinical outcomes. So this is very important and an extra very interesting to improve the health of your patients. Second, avoidance of harmful substances. Smoking increases the risk of developing type 2 diabetes. So don't forget that smoking cessation should be included in every lifestyle prescription. And also stay aware of technology, because continuous glucose monitoring has been shown to reduce glycate by approximately 0.4, even among people with diabetes who are not treated with insulin. So it will be also an important thing to not forget.
Rosalia, shall we leave this for the Q&A session if we'll have time?
Okay, just
So just a closing sentence, sorry.
okay, a closing sentence. So key take home message. there are 5 sentences. Once I only can choose one, type 2 diabetes remission is indeed achievable and measurable. So let's do this, because we have a new paradigm shift that actually can reaches our patients from the clinic. So thank you very much for your attention. I'm sorry for running out of time, but indeed the most important things were sharing with you, and I will be happy to take questions at the end of all presentations. Thank you.
Thank you so much. Thank you. Kate, your stage.
Thank you, Rosalia. And I'm going to share my screen now. I'm assuming you can see that. Everybody, please do interrupt me if you can't. So I'm Kate. I'm the Clinical Director of the British Society of Lifestyle Medicine Learning Academy. And thank you so much for having me here today to talk about addressing barriers, promoting adherence and long-term sustainability in the context of lifestyle medicine for type 2 diabetes remission. So I'll think about today what barriers an individual might face when putting and integrating lifestyle change to manage or put their diabetes into remission, and also how these barriers can be addressed to promote long-term sustainability. So I'll start off with, I'll frame this with a definition of lifestyle medicine as as the British Society of Lifestyle Medicine think of it. So that's acknowledge and the need for action on the social determinants of health, use of the 6 pillars of lifestyle medicine, as Rosalia has outlined for us, and the use of proven techniques to support people in lifestyle change, which Tahila is going to speak about later. So the British Society of Lifestyle Medicine define lifestyle medicine in terms of these 3 principles. And really, when we're talking about barriers to lifestyle change and how to promote long-term sustainability and alleviate those barriers, really we're focused on the social determinants of health that often are the creators of these barriers. So there are any number of statistics that I could have shown you to evidence the effects of the social determinants of health in lifestyle in type 2 diabetes, but I've chosen this one which comes from Diabetes UK, and that's in terms of people under 40, or so those people who've been diagnosed really quite early with type 2 diabetes, 34% live in the most deprived areas, compared to only 9% living in affluent areas. And that's really showing the gradient in diagnosis of type 2 diabetes and how social determinants of health are really affecting this. And these people have ultimately earlier diagnoses. They're unfortunately, according to other literature, less likely to attain a treatment target, and they ultimately are more likely to have ill health and complications of their disease. So it's so important that we think about how to support people overcoming these barriers. So what might the barriers be? I'll think about this organised by lifestyle medicine pillar, just to give us a bit of a structure. So starting with the nutrition pillar, which, as Rosalia mentioned, is one of the central pillars when we're thinking about type 2 diabetes remission. So here we need to think about barriers such as food insecurity. That's where people might not necessarily have the financial means to acquire the food they need to eat a healthy diet. So that might mean, so for example, if you're on a lower salary, you'll need to spend a much larger proportion of your disposable income in order to eat what we would consider to be a healthy diet, compared to if you're on a higher salary. And there may also, it is possible to eat well on a low budget, but you need knowledge in order to do that. So people may not lack knowledge or even facilities to prepare healthy food. If they've got suboptimal accommodation, they might not have kitchen access, they might only have a hob and not an oven. Also, if they've got complications of type 2 diabetes, so maybe a more advanced stage now, then such as neuropathy, they might struggle to hold a knife. There's also these things called food deserts and food swamps. So food deserts being locations in the country where it's very difficult to get healthy food, so it might be very rural, there might not be a lot of shops, and they might have to travel a long way, or it might be in an inner city area, you might have only corner shops and not sort of supermarkets that sell healthy fresh food at a accessible cost. Food swamps, on the other hand, are areas where you might find lots and lots of fast food outlets concentrated in a geographical area, which means that people are sort of under pressure it creates a pressure to eat unhealthily. Makes it more difficult to follow a healthy diet. Then you've got the mental well-being pillar. So coexistent mental health difficulties might affect executive function and difficulty following a lifestyle program. You've also got the psychological drivers of eating behaviours. It might affect people's motivation, and this can all be driven by social and financial stress, which make mental well-being worse. Moving on to physical activity, you might have physical limitations to activity due to chronic ill health. You might have symptoms such as fatigue. People with type 2 diabetes might also have glycemic challenges, depending on what other medications they may or may not be on. More generally, people might lack a safe space to exercise. If they don't have a safe, free space to exercise, there might be financial barriers, for example, to gym membership or to buy the equipment needed for physical activity. There also might be psychological or cultural barriers. If someone's overweight, they might find it difficult to exercise somewhere that they feel that other people can see them. And in certain cultures, it might not be looked upon well to be doing physical activity in front of others. Thinking then about harmful substances, these are often subject to social pressures, and they might also be seen as a coping strategy for social, psychological or economic stresses, which then acts as a barrier to people resolving these behaviours. Coming to sleep, if you're experiencing socioeconomic adversity, you might not have a conducive, silent, dark, comfortable sleeping environment. I had a patient last year who I was supporting with her type 2 diabetes, whose sugars were really out of control. And this was despite eating well and exercising. And actually, when we explored it, she was living in a house that she had for just her and her partner. But unfortunately, because they didn't have housing, her son and his young family had moved in with them, and they had used all of the bedrooms. So this lady was sleeping on a sofa in the kitchen because there was nowhere else for her to sleep. And that meant that she had a very uncomfortable sleeping environment, and that there were people coming in all times of the day and night. So she was not being able to sleep well, and that was impairing her glycemic control. Also, if people have got psychosocial stresses, they may contribute to sleeping difficulties. Finally, in terms of social connection, we've heard from Rosalia how this can be harnessed to support a healthy lifestyle, but also, unfortunately, social pressures and norms can also be a barrier to lifestyle change. We've also got to consider intervention-specific challenges. We've heard about different interventions that can be used in the context of diabetes remission, and they may have their own specific barriers to that, that's relevant to that intervention. So what can we do? The first thing to say is we will not recommend blanket lifestyle advice, and because this can actually increase inequality and unhealthy behaviours. People who are subject to socioeconomic challenges to lifestyle often don't have a lot of agency, or might not, a lot of things are happening to them in terms of their circumstances rather than them having a lot of control. So giving blanket lifestyle advice to everyone often makes these gaps wider. Instead, we can use things like coaching questions to identify and overcome barriers and establish sources of support. So you might ask them how confident they feel in being able to make a particular lifestyle change, what barriers they could perceive that they might encounter, and ask them to advise themselves about how to overcome this. And then they can really tailor it to their situation and the particular circumstances they can find themselves in. You might also ask them if there's anything they could do to increase the likelihood of making the change successfully. In terms of long-term behaviour change and supporting adherence, we can think of this in terms of the behaviour change cycle, which I won't go through in detail because I hope you're all familiar with it. But basically, matching what we do to the stage can be really helpful. So in preparation and action, we make sure that they're setting realistic goals. And I know Tahila's going to speak more about goal setting. We support them to anticipate barriers and strategize solutions. When they're maintaining their change, we can reinforce success, help them build self-efficacy, and we can identify relapse risks with them and help them action plan. If they do have a relapse, we can normalise this and support them to learn from it, strengthening their networks of support and revisiting the goals that they wish that motivated them in the first place. And through that, we can achieve, and hopefully, an upward spiral of improving lifestyle change. So in summary, my top tips: be aware of potential barriers, but avoid assumptions and advice. Meet the patient where they're at, find out what's important to them, and elicit their own strategies to overcome barriers and avoid relapses. So thank you so much for listening. Please put your questions in the chat for the combined Q&A at the end. If you want to contact me, here's my email address, and just a bit of information here about my organisation, the British Society of Lifestyle Medicine, and a code for membership if you should wish to join us. And we've also got our core accreditation and a range of educational programmes around this topic as well. So thank you so much.
Thank you, Kate. I'm going to present my slides now and share them. Hope you can see them.
Yes.
Great, thank you. Okay, so good evening, everyone. Thank you very much, Dr. Lilach. Thank you very much, Dr. Rosalia, and thank you so much, Dr. Kate. So while we often, I'm going to present a presentation, and the topic will be behavior change tools for diabetes remission, from evidence to action in primary care. While we often discuss the evidence behind diabetes remission, my focus today is the how, the clinical skills we use inside the consultation room. So patients usually know what to do because we give them the information, or what to do. Our challenge as family physicians is helping them make it happen. So I will share 4 practical tools used with patients. For example, I'm going to give an example of a patient of mine, Maria, to bridge the gap from evidence to action. Okay, so meet Maria. She's a 52-year-old teacher with newly diagnosed type 2 diabetes. She sits most of the day, struggles with stress eating, and barely sleeps 6 hours, usually 4 to 5 hours a night. She represents the patient we see every day, I suppose. And the question is, where do we start? So we know from studies such as Direct and Look Ahead, as Rosalia mentioned earlier, that meaningful lifestyle change can lead to diabetes remission. But evidence alone does not change behavior. Patients rarely change because we provide more information. Behavior change occurs when we help patients connect their health goals with action they feel capable of taking. That is where clinical skills become essential. So when I work with a patient such as Maria, I rely on 4 practical tools. Obviously, there are many other tools. These are the main ones I use, and I think are easy to learn and practice. Like Rosalia said already, tomorrow morning, if you work on Fridays or on Sunday or Monday with your patients in the clinic. So I'm going to be talking about the first tool is motivational interviewing. The second tool is SMART goals. Third tool is self-monitoring. And the third is addressing sleep and stress. So each can be incorporated, as I said, into routine primary care practice easily. And I'll just mention here the 5 A's. Hopefully you know about them. The 5 A's is an evidence-based behavior change model, often referred to as the 5 steps for intervention. They're used as is and also as part of the motivation interview. They encourage patients to engage in self-management. Came up with is actually a comprehensive communication approach that takes time to master. But today I would like to focus on three simple, well, I'm going to focus on the basics of the. I'll show you a few questions, basic questions we can ask patients as part of the motivation interview. So we have the PACE spirit as part of the interviewing, the partnership, the acceptance, the vocation, and compassion, using compassion with our patients. And there are four processes as part of the motivation interview. The first one is engaging, establishing a helpful, trusting, and collaborating working relationship. This is the foundation. The second is focusing, developing and maintaining a specific direction in the conversation about change and setting the agenda. And we actually ask our patient and have them choose what is the agenda. Evoking, eliciting the patient's own internal motivation for change. That's the core of motivation interviewing, is the inner motivation of the patient. And planning, developing communication, the way to change and formulating a concrete plan for action. So motivation alone is really, so the ORARS, one second, I can't see part of my slides. Okay, matrix in action. So help resolve ambivalence and find the motivation within. So ambivalence is a big part of a motivation interview, and we should take note of it and put it on the table, as we say, and listen to the ambivalence of the patient and hope them resolve it. So how do we do a motivation interview? How do we go about it? So we should use open-ended questions like what matters most to you about your health right now, reflective listening, you're feeling over that you're clear that you want to protect your future health, for example. Affirmations, it takes courage to face a new diagnosis while managing high work stress, for example. And summaries as part of the interview and also at the end, pulling it all together to transition to planning. So the evocation breakthrough, for example, is instead of moving from telling the patient what to do, like you need to lose weight, we want to use these different techniques of motivation interview to have Maria respond to, for example, I don't want to develop complications or health complications like my mother. So suddenly there's an internal motivation that's unlocked. And usually, and what we recommend is to have the patient come up with the solutions. So after we gave them some information, and usually they also know a lot, but we can give them obviously counseling and information, but we hope them come up with the different ideas and solutions or SMART goals, which I'll give you an example for, that mostly suits them and their lifestyle and the preferences. So together, Maria and I agreed on the following goal, for example. For the next 2 weeks, I will replace my evening cookies with fruit and nuts at least 5 days per week. So you might ask yourself, but she has a new diagnosis of diabetes. How come we are giving her fruit? So we know already that you're allowed 3 pieces of fruit also for people with diabetes per day. And also think about that we want to make small steps. And she wants this sweet food in the evening. I will explain more about it soon. And replacing it with like vegetables might not do the thing, but we can replace it with a healthier carbohydrate, right? So fruit is healthier, and if you combine it with a nut, so we know that combining it with a nut that has protein and a healthy fat, it reduces how fast the sugar levels go up in the blood glucose levels, and it also rises more slowly. So SMART goals are made up of specific, so like fruit, nuts versus cookies. Measurable 5 days per week, for example. Achievable, it's a small swap, as I said, not big steps, but a small step to make. And it's something that she feels that she can do and she's interested to do, and she likes fruit, for example. It's relevant. It's addressing the topic of the snacking in the evening and having cookies. And we want to reduce her levels of the glucose in her blood. And time bound, so for the next 2 weeks. So motivation starts change, SMART goals sustain it. So I want to give more examples of SMART goals, for example, except for just nutrition, or how do we go about SMART goals instead of having like vague intentions. SMART goals help us make it more focused, more time bound, and how we can really monitor it, the change. So instead of saying I will eat healthier, so I can, the SMART plan will be I will prepare 3 home cooked meals per week instead of ordering out. Or social and stress, because she's a person that has stress and doesn't have a lot of time. So I will spend more time with my family, versus SMART plan will be I will prepare a meal twice a week and eat it with my family at the table, which is part of our lifestyle medicine recommendations, right? For Mediterranean eating and around with the family around the table at home. So this addresses 2 topics, also the eating and also the social. And sleep, I will try to sleep better. So the SMART plan will be I will go to bed between 10 and 11 p.m. instead of at least 3 times a week instead of after midnight. An environment, for example, will be I will look at my phone less. So the SMART plan will be I will remove my cell phone from the bedroom every night before sleep. And so when discussing so one of the most powerful behaviors that come to the third tool is self-monitoring. So it's a powerful behavioral change technique is where we often ask patients to change before they fully understand their own habits. So Maria completed a simple food and sleep diary, which I'll give you an example of, and she quickly identified late night snacking, insufficient sleep, and stress-related eating. Awareness often becomes the first step towards change. So we can ask our patient to please monitor, have a kind of like diary for the next few weeks. And the example will be write down the time and the food that you ate when you feel that you shouldn't have had and you did, and the activity that you did that you preferred not to, for example, and what happened the same day, or what feelings came up also when doing it. And then she found out that she discovered the link between late night snacking, stress, and poor sleep, for example. Without doing this, she wouldn't be aware of it. And this gives us a chance to really help her specifically with her challenges. So when discussing diabetes remission, we often focus on food and physical activity, as Rosalia explained. And really, these are the 2 main pillars of lifestyle medicine. But sleep is also deserves equal attention, and stress. So stress, I think, needs a whole webinar on its own. But I just wanted to mention sleep. A lot of times we don't ask our patients how's the sleeping behavior, as Kate did mention and give a very good example. Thank you, Kate. So sleep is a very important component to treat glucose levels and diabetes remission. Poor sleep is not only a consequence of chronic disease, it's also a contributor. So I always tell people that except for psychological stress, you also have stress for the body. So even if you don't feel stressed, but if you're not sleeping enough, your body's stressed. And what happens when we're stressed? So the cortisol and sympathetic activation, the cortisol goes up. Insulin resistance becomes worse. Fasting blood glucose goes up. And reduced capacity for behavior change and increased cravings occur. And there's a scientific basis for this. Sleep restriction increases activation of as we said, so experimental studies have demonstrated that even a few nights of sleep restriction can significantly reduce insulin sensitivity. Spiegel and colleagues showed that healthy young adults restricted to 4 hours of sleep exhibited impaired glucose tolerance in endocrine changes resembling accelerated aging. Large epidemiological studies have also shown that a short sleep duration is associated with a significantly increased risk of developing type 2 diabetes. These findings remind us that sleep is not simply a quality of life issue, it is a metabolic risk factor.
Hila, we have like 1 or 2 minutes because we want to have some questions.
Yeah, sure. So the prescription or sleep hygiene prescription I can give, I'm almost finished, give Maria, for example, these recommendations that actually Kate already mentioned, most of them, is the duration of sleep, the environment, the schedule of going to sleep and waking up at the same time. As infants, I say also the adults need that. Don't have caffeine after noon, and don't finish eating at least 3-4 hours before bedtime, and so on. And 0 screens at least 1 hour before sleep. So we can give her this information, ask her which would you like to, or which do you think is relevant, or would you like to manage and change, and we can have a SMART goal with these recommendations. So take-home messages, the new standard of care. So behavior change is a clinical skill. It requires structure, not just advice. Use brief motivation interview questions. Ask, don't just tell. Find the internal motivation. Set SMART goals. Transition from vague intentions to trackable actions. Treat sleep as a metabolic medicine. Monitor it as closely as diet and exercise. And I want to invite you to our Wonka Europe Lifestyle Medicine Special Interest Group. You can use the QR codes to become a member, or to see our page with the different tools and information we have there in the Wonka site. And I hope to see you in the 30th Wonka Europe Conference in Paris. Thank you very much.
Thank you so much, Tehila. Thank you all, Kate, Rosalia. We are approaching now the Q&A session, and we have a few questions in the list. So I want to have the first very, very interesting question to Rosalia. Alessia is asking, who can be a good candidate for a diet of 800 calories per day for 12 weeks? Could it lead to a muscle loss, nutrition deficit, fatigue, and could it cause rebound effect? I think you discussed that at the direct trial, right? About the very strict diet. So what did they say about it, or what can you say to Alicia about that?
Okay, thank you, Alicia, for the very interesting and relevant question. Indeed, only for very motivated patients it can works, because it is very restrictive, and in direct study it was very like this, very motivated patients, young patients, and which that patients could also indeed perform an exercise program alongside the diet. So this is also important, not to have lean muscle going down, because muscle loss, it is not a good indicator to our health. And yes, if we don't have a motivated person, also we can have fatigue and we can cause rebound effect. Indeed, I think the motivation, it is the very central question, because it was the evidence also, it was what the evidence also showed to us. So motivate, I think it's in one word the answer.
Yeah. Well, I have a patient who came to me and he was diagnosed with diabetes, and he said, I don't want diabetes. Tell me what to do. So this is a guy who really now, 3 or 4 years after after he had diabetes, that he's still keeping this, and is under every 6 months we have a blood test and everything, because he didn't want diabetes. And he said, I'm not going to be sick with this disease. So it is possible, but he is very high motivated, and we can add this this thing to choosing the patient, choosing the right patient, as you discussed earlier, Rosalia, about what patients are we going to choose into this program. Thank you. So I want to have another question to Kate. There is a question about, is nature exposure not part of lifestyle medicine? I am surprised not to find this in the pillars, whether scientific evidence in the improvement of both mental health and physical health is strong.
Thank you for that question. And yes, absolutely. Nature exposure is so important when we think about lifestyle medicine. For the reasons that you outline. But the reason that it's not one of the pillars is that certainly at the BSLM anyway, we think about it as a cross-cutting theme across lifestyle medicine, because it does connect with physical activity in terms of doing physical activity in nature. It connects with mental well-being, as you say, sort of independently improves mental well-being. It connects with sleep in terms of getting natural light in the first part of the day, and also with healthful eating in terms of eating, fresh and natural foods in their whole forms. So in terms of that, it does really cross-cut a lot of the pillars, and so it's thought of as a cross-cutting theme rather than a pillar in and of itself, but it is absolutely something that's really important. So thank you for highlighting it.
Yeah, there's a lot of things that can be connected, but there is like also sexuality and other things, but we stick to this 6. Maybe, when the time comes, we'll add more. We don't know. This is what it is now. Okay, so there's one more question, Teila. It's about sleep. You discussed sleep pattern and how it affects diabetes, and Kaldum is asking, if sleep can do diabetes, what about doctors? How can manage it in the real life where there is stress life and a lot of work? So how can we solve this problem?
Okay, thank you very much. Great question. Thank you for that. We teach healthy doctor, healthy patient. And when I give my course for lifestyle medicine for residents in family medicine, I always tell them it starts with us. First of all, this is information and tips for you, for your life, for you being healthier, and then for your patients. First, practice on yourself and family and loved ones, and then with your patients. Obviously, these are recommendations that we should also follow. And we should invest in our health first, and our example will be the best for our patients too. And healthy dealing with stress and healthy sleep hygiene is so important, and we must do the most we can to improve it. Of course, I agree.
Great. Thank you. So we are approaching almost the end of this webinar. There is one comment that I think it's important to read up from Vico Tabian. Thank you for that. So Vico Tabian wrote for us, perhaps just a comment. Very important to know that lifestyle medicine is the foundation and must be maintained and nurtured exactly into what it is, a lifestyle, especially in the world of information, GLP-1, etc. It is important to highlight that it is a multifactorial approach, not a one-time quick solution. So I think it's a nice end of this discussion. We understood that diabetes can be a disease that we can eliminate from the patient. Remission, as Rosalia said, it's not for good, maybe, but it can be under remission for a very long time. We found some barriers that we can talk about with the patients and find solutions for them. Teila told us about the way how we discuss it with patients. So I hope this is like a kind of looking at this idea from many angles, and it helped you to work with your patients, and just we urge you to try it at home with yourself, with your patients, and also with your family. So we invite you, the special interest group of lifestyle medicine is working in the last 4 years. We are growing. So we invite you to be part of it. It's in Wonka site. We have also the Lifestyle Medicine 6 site.